Hello and welcome to Internal Medicine, where we talk about ER topics and we talk about internal medicine topics. Today we're going to be doing a LVAD case, or left ventricular assist device. We're going to talk about how these patients are different than your average patient. We're going to talk about how history and physical can help narrow down some of this differential diagnosis. We're also going to talk about how different LVAD alarms and different LVAD parameters can also help with our differential. We're going to talk about some basic treatments for these patients. We're going to talk about when it's safe to do CPR on them or when it's necessary to do CPR. And then to put it all together at the end, we're going to do a board-style case to help improve everybody's scores on tests. So without further ado, let's get talking.
So this is a case of a 58-year-old male with a history of end-stage heart failure on a left ventricular assist device, or LVAD. He presents to the emergency department after his LVAD alarm activated at home, followed by a brief episode of syncope. He reports feeling lightheaded and dizzy immediately before losing consciousness for approximately 30 seconds. His spouse found him on the floor, unresponsive but breathing. He denies any seizure-like activity, chest pain, or shortness of breath. He felt weak and dizzy after regaining consciousness but has not experienced any further episodes. His wife reports an alarm from the LVAD was noted. Past medical history of CHF with an ejection fraction of 15%, hypertension, paroxysmal atrial fibrillation, diabetes mellitus type 2, chronic kidney disease stage 3. His surgical history is positive for an LVAD, a HeartMate 3 specifically, which was placed 3 years ago. The patient also has history of PCI. He quit smoking 12 years ago, has no alcohol or illicit use, and only a family history of hypertension. His medications, he has a list, but is aware that he's on a blood thinner, but cannot recall the name of it. Otherwise, he takes carvedilol 25 milligrams BID, lisinopril 40 milligrams daily, Lasix 40 milligrams daily, metformin 500 milligrams BID, and pantoprazole 40 milligrams daily. Nursing notes that they are unable to take a blood pressure on the patient, but they have reported his heart rate is 72, respiration's 18, and oxygen saturation is 96% on room air with a temperature of 98.2. In general, the patient appears fatigued. On cardiovascular exam, there's no audible heart tones present and no peripheral edema noted. The patient's respirations are clear to auscultation bilaterally. The abdomen is soft, non-tender, non-distended with positive bowel sounds without palpable masses or hepatosplenomegaly. Neurologically, you note no gross motor or sensory deficits, and his extremities show no edema with no pulses noted. So to understand the differential diagnosis as well as approach to a patient with an LVAD, first we have to understand a little bit about the device itself. So it's a pump that supplements cardiac function in those with end-stage heart failure. Basically, blood is pumped from the inflow tract, which connects to the left ventricle, to the ascending aorta via an internal pump. Older versions of this use pulsatile flow, and new versions use continuous flow for better energy efficiency. This continuous flow is why a lot of these patients won't be noted to have a pulse. Externally, this pump is connected via a drive line that's placed underneath the skin, and then that connects to a control unit, which monitors operations and initiates alarms. It's then connected to a battery. Patients should generally be carrying 4 to 8 of these at any given time. The 3 main reasons to place an LVAD in a patient would be a bridge to transplantation, a bridge to recovery, meaning that they have a cause of heart failure where they're expected to recover. This might be something from myocarditis or postpartum cardiomyopathy, or maybe they're trying a treatment option that's expected to recover their heart. And the third reason would be a destination therapy, meaning that the patient has a low chance of transplant, and this is the last thing they can do for their heart failure. Also, speaking of equipment, the contact information for the physician the physician that's in charge of the patient's LVAD should be in the bag with the patient's extra batteries. So here you can see the control unit for an LVAD. There's various different alarms that can be indicated from this. There's the AOK sign that's there is the pump running symbol, and if that's green, any of these units are going to be connected to 2 different batteries. The unit will drain power equally from each of the 2 batteries that it's connected to, and they equal about 17 hours of power. As power is drained, when you get closer and closer to that yellow diamond in battery capacity, that means that it's going to start running on the internal battery, which means you have 15 minutes left, which will also trigger a yellow alarm. There's a red alarm that also indicates that the battery has 5 minutes remaining. To review alarms on the display, Specifically for the HeartMate 3, you push the display button and the silent alarm button together. So here we can see a report of a low flow alarm that's dated and timed. There's also a system display monitor where we can see pump flow, pump speed, pulse index, which is pulsatility index, and then the pump power, which are four main parameters. Understanding some of these parameters can help us understand alarms and the complications of the LVAD. Starting with pump flow, this is rotator speed, which is 3 to 6 liters per minute on this device. Flow is affected by volume status. It's very preload dependent and afterload sensitive, meaning low preload states will cause decreased flow, and high afterload states will also cause decreased flow. The next parameter, pump speed, this is in rotations per minute. This is prescribed by the cardiologist. It ranges from 4,700 RPMs to 6,200 RPMs with a medium speed of 5,400. Power, which ranges from 3 to 6 watts, correlates with increased pump speed. High power means the pump's working harder, and this generally correlates with flow. The last parameter is pulsatility index. This is the variability in pump power during systole and diastole of the patient's own natural heartbeat. This is averaged over 15-second intervals and ranges from 1 to 10. Indirectly, you can think of it as a measurement of the patient's own cardiac contractility. So now that we know a little bit more about the parameters and how to monitor someone, first we should figure out, is this person alive because they don't have a pulse? So there's a very specific way you gain blood pressure information about a patient when they have an LVAD. You have to use a manual blood pressure cuff and a Doppler to check pressure, either the brachial or radial artery. So step one, you're going to locate the radial artery with your Doppler device. Step two, you're going to inflate your blood pressure cuff until you no longer hear any auditory flow. Then you're going to want to pump an extra 20 or 30 millimeters of mercury over that. Then, with your Doppler placed on the radial artery, you slowly release pressure from the manual cuff. The map is determined at the pressure where the arterial flow is again heard via Doppler. A normal LVAD patient has a map between 70 and 80. Greater than 90 is hypertensive in these patients and makes them subject to both hemorrhagic and ischemic stroke. Other physical exam cues that can give us a sense of cardiac activity would be perfusion, so gauging the patient's mental status, looking at cap refill, looking at warmth of their extremities. Another thing we should do is listen for a machine hum or whirl, meaning that the LVAD's working. Pulse oximeters can be unreliable, so if you're concerned about hypoxemia based on a pulse oximeter result, then consider ordering an ABG. So next we have to think about what alarm went off. So let's review some of the common LVAD alarms, starting with power. Low power indicates battery depletion, or the patient was disconnected from the power device, or possibly that the cord is damaged. So evaluating the LVAD device for batteries as well as if the drive line's connected would be appropriate. A high power alarm can be associated with pump thrombosis. It means that the LVAD's working extra hard. Can also be associated with outflow graft stenosis. Pump thrombosis can be diagnosed by echocardiogram. I imagine formal. It can also be seen in cases of hemolysis, which can be gauged by checking an LDH, which is 2.5 to 3 times the upper limit of normal. So hemolysis can result in pump thrombosis. The third thing to consider with high power alarms would be a hardware malfunction itself. The next alarm to consider would be flow. So this can be low or high. Starting with low, the first thing to think about would probably be hypovolemia. This patient would have a low MAP. Maybe they've had overdiuresis. Maybe they've had volume loss symptoms like gastrointestinal, nausea, vomiting. Maybe they've had third spacing from a disease process. Pump thrombosis, which either in the inflow or outflow obstruction or in the pump itself, results in a low flow state. Right ventricular failure from any of its multiple causes. This can be acute or chronic. So other things that cause RV failure would be like tamponade, pneumothorax, saddle pulmonary embolism, worsening pulmonary hypertension. Arrhythmias also decrease preload and thus drop. They can cause RV failure, but also drop preload for the same reason, indicating a low flow state. Hypertension, which can be from volume overload or from hypertension itself. This causes increased afterload, which thus reduces the flow. Kinking or malposition of the outflow graft. This can be diagnosed via CT and is a mechanical complication of the LVAD itself. High flow states can be caused by things like aortic insufficiency. This can be diagnosed via echocardiogram where backflow is seen through the aortic valve. Sepsis or hyperdynamic states can result in high flow. This is due to a drop in afterload from vasodilation from sepsis. It also is caused by the high cardiac output from the hyperdynamic state of sepsis. Left ventricular recovery can also cause high flow. This is very rare. It's 1% of patients at 1 year and 9% of patients at year 3, which is also diagnosed via echocardiogram. In general, changes in flow should also match changes in power. So if there's low flow state, less power is needed in the pump. If there's a high flow state, more power is needed. The only exception to this rule is pump thrombosis. So if the pump itself is clotted, there's going to be less flow, but the pump's going to be trying to work extra hard to create flow. The last parameter to talk about is pulsatility index. Pulsatility index is the change in power divided by the average flow. A change in greater than 45% from baseline will trigger a PI event. This can be due to quick preload afterload changes. This can be from transient events like moving or coughing or sneezing. So we're going to talk about a differential diagnosis for low pulsatility index. Take some of this with a grain of salt. There's different manufacturer specifications. But overall, if you think about this as if the patient's heart is increasing in function, then their pulsatility index increases. So having a low pulsatility index means the pump is having to work harder. So this can be from things like hypovolemia, it can be from pump thrombosis, right ventricular failure, arrhythmias, suction events. So suction events specifically, I want to talk about because they're a unique complication to LVADs. In any low preload state, the LV will collapse and the inflow cannula can suck down against the LV wall. LVADs will try to slow their own RPMs to temporarily allow the LV to expand in an effort to correct this, but if sustained, it can result in hypotension. It can be diagnosed by bedside ultrasound showing low left ventricular volume. The treatment would be for volume expansion via intravenous fluids. These suction events can present as syncope, or sometimes they can present as arrhythmia. Aortic insufficiency, flow back through the aortic valve, which can be seen in echocardiogram. There'll be less variability in the LV volume equaling a low pulsatility index. So high pulsatility index can be caused by things like hypertension, it can be caused by fluid overload, and then that rare circumstance of LV recovery. So again, a lot of these are hypertension or high afterload states. So with hypertension, that would be simply to check the patient's blood pressure and see if their MAP is running high. Otherwise, for fluid overload, you could judge if the patient had any jugular venous distension, pulmonary edema, extremity edema. And left ventricular recovery would be diagnosed by repeating a formal echocardiogram. So let's think about what our differential diagnosis is, assuming that we are able to get a blood pressure on this patient and they have a MAP of 60. So any patient that has low blood pressure, we're doing a very similar differential, but let's see how that applies to an LVAD patient. We're going to think about different kinds of shock. So starting with distributive, septic's going to be the most common since these patients are so prone to infection. As a secondary thing, we could consider things like anaphylaxis, neurogenic shock, or like adrenal insufficiency, but they become much lower on the differential. Hypovolemic shock, due to volume loss, these patients are so preload sensitive, so this would be very high on the differential. This can be from volume loss from things like gastrointestinal, nausea, vomiting, diarrhea. It can be from changes in diuretics. It can also be from hemorrhage, from blood loss. When we think about cardiogenic shock, acute myocardial infarction is usually the most common thing that causes that. In our patient specifically, we'd want to look for right ventricular involvement of a acute myocardial infarction because this patient would have to drop their preload, their LV functions being sustained by the LVAD itself. We'd also want to consider things like arrhythmia, which affect preload, onset aortic insufficiency, as well as right ventricular failure, which patients are prone to produce with LVADs. We would also want to consider some obstructive causes of shock. Things like tension pneumothorax, massive pulmonary embolism, which is a little less likely since the patient's going to be on blood thinners anyway, but if they were subtherapeutic, they could certainly develop a PE. Tamponades a common cause, especially in patients after they've recently had an LVAD placed. Other obstructive causes that are more unique to an LVAD patient would be an inflow or outflow tract obstruction. These can be from kinking of the mechanics itself or sometimes caused by clot formation. Take a minute and think about our differential diagnosis and think about the foil and what we know about our clinical case so far, and then see what other information would have to be included in this case or what other things should we look for to make this diagnosis. So starting with the most common cause of this, hypovolemia. We'd want to look for things like dry mucosal membranes. Maybe they'd have a low CVP. Maybe they'd have orthostatics. We'd want to ask them specifically about history of volume loss. Maybe they just had their diuretics doubled. And to look at the actual parameters of the LVAD itself, we would see things like a low flow state with a decrease in power. The pulsatility index should be low or possibly variable depending on what model device you're using. With this hypovolemia, we'd also want to look for specifically one of those suction events, which we could look at by doing a bedside echocardiogram showing that decreased LV volume. Next, let's think about sepsis and how our patient would be affected. So, septic sources can be LVAD related or non LVAD related. So, they would have signs and symptoms of an infection. They would have things like fever or tachycardia. Driveline infections are some of the most common areas of sepsis for patients with LVADs. We'd want to make sure to inspect the line itself, seeing if it was tender to touch or seeing if there was any discharge from that site. Bacteria that cause this infection are related to immunocompromised patients. It's a slurry of gram-negative organisms as well as gram-positive, so things like Staph aureus, Staph epidermis, Enterococcus and Pseudomonas, Klebsiella, Enterobacter. You can also have fungal infections related to the drive line. Another source of infection would be a pump pocket infection, which is either the pouch that's in the pericardium or abdominal cavity, depending on which LVAD device you have. Another high mortality infection would be endocarditis, which has a mortality of approximately 50%. As far as changes in LVAD parameters related to sepsis, this is going to be a high flow state with high power. The vasodilation that accompanies sepsis drops the afterload and increases the flow. Another example of a patient that may present with the same high flow, high power state with hypotension would be if their shock was related to medication changes. So let's say the patient got started on hydralazine recently. So there's a vasodilator, it's an afterload reducer. Maybe it's too much for them. So they would present with the same hypotension, high flow state, and high power, just without the signs of infection. Next on our differential would be hemorrhage. This is another very common occurrence for LVAD patients. It's about 15% of patients develop bleeding at 1 year, where gastrointestinal bleeding by far is the most common area of bleeding. But the patient may have other symptoms like melena. Maybe they'd have epistaxis if the bleeding was not related to a gastrointestinal source. So a good question to ask is, why are these patients so prone to bleeding? Well, some of it might be that quote unquote blood thinner that the patients, in patients with LVADs, warfarin is the medication that's been studied. Depending on the specific model, there's different INR goals. Some require an INR of 2 to 3, some require an INR of 2.5 to 3.5. These patients are also going to be on antiplatelet medication more than likely, as coronary artery disease is a very common cause of cardiomyopathy. They're going to be prone to intestinal bleeding, specifically in the small bowel, because these patients are prone to develop AVMs. They also have an acquired von Willebrand's disease. This is due to consumption of von Willebrand's factor, which leads to poor platelet adhesion. Another patient that might get something similar to this would be a patient that has aortic stenosis, and this combination of von Willebrand's disease and bleeding related to a cardiac cause is also known as Hyde syndrome. When we look at the parameters this patient's going to have, we're going to notice again they're going to have a low flow state and low power. Their pulsatility index again is going to be low or possibly variable depending on the device. And what would I do for treatment for this person? So I probably would transfuse them as needed. Depending on the threat to life the bleeding's having, you may consider emergent reversal of warfarin. This would be with things like vitamin K and fresh frozen plasma, maybe Kcentra. For the specific von Willebrand's disease that's acquired, we could consider DDAVP as well as cryoprecipitate transfusion. Patients that are hypovolemic from hemorrhage should also be checked for a possible suction event. Pump thrombosis can be another cause of shock. It has varying degrees of presentation from mild symptoms all the way to cardiogenic shock. The HeartWave 3 device model that we're talking about today is supposed to be less prone to clotting. I think it only needs an INR goal of 2 to 3. So other things we should look for would be hemolysis. It's weird that thrombosis leads to intravascular hemolysis. So we would see laboratory changes. We would see an elevated bilirubin, and some of the main diagnostic changes we'd see is that elevated LDH greater than, I think it's close to 3 times the upper limit of normal. As far as parameters for the LVAD, we're going to see a contradiction. We're going to see a low flow state with a ton of power trying to get over the clot that's in the pump itself. For the pulsatility index, this could be low. So for treatment for this, we might consider anticoagulation if they were subtherapeutic on their Coumadin. We would also consider things like arrhythmia. Ventricular arrhythmias are by far the most common. They can be due to primary causes or secondary causes related to the LVAD itself. Symptoms with SVT and ventricular arrhythmias, they're not going to have as much symptomatology for this since their left ventricle is already taken care of. So it's only when an arrhythmia causes RV failure and a drop in preload is when you start to get symptoms. The patient may complain of elevated heart rate or palpitations, but if it becomes persistent, hits the right ventricle, then the patient will become hypotensive. So these patients are going to have low flow states with low power and low pulsatility index. Treatment is based on severity. So if the patient's arresting, then it would involve either defibrillation or cardioversion. If you do need to do this, the pad placement's a little bit different because you don't want to fry that wire. So you want to use the anterior and posterior placement to avoid the drive line. Medications, these patients all have diseased hearts, so an antiarrhythmic of choice for them would be amiodarone. A lot of these patients, because their EF's low, have an ICD to begin with. We also said that suction events, one of the presentation symptoms for this besides syncope would also be arrhythmia. So it wouldn't be necessarily a bad idea if somebody had VTAC and their heart rate was 190. If they were stable-ish, you might want to consider just giving them fluid first for the presumption of a suction event to treat the arrhythmia. So getting into some more cardiac causes, aortic insufficiency can result in shock, but more likely would present as acute heart failure. This can lead to right ventricular failure, which causes the shock. It can also lead to things like arrhythmia. So a lot of these patients are going to be fluid overloaded, signs of heart failure, edema, JVD, pulmonary edema, lower extremity edema. And aortic insufficiency is pretty common. It occurs in up to a third of patients at 3 years. It's because of this continuous reverse pressure gradient that's elicited by the pump that puts all that pressure on the aortic valve and then eventually results in insufficiency. As far as parameters go, you'll notice increased flow, increased power, and then possibly a decrease in pulsatility index. This is diagnosed via echocardiogram. Cardiac cause would be from tamponade. These patients are anticoagulated. We would see signs and symptoms of heart failure. This is not necessarily common, but probably more common in LVAD patients. It's 3.2 to 7.2% of patients may have cardiac tamponade. As far as parameters, this will be a low flow state and a low power with the high pulsatility index, which is what the manufacturer says. This is diagnosed via echocardiogram, and the treatment is emergent paracentesis. Right ventricular failure is another common occurrence in LVAD patients. It's 9 to 40% of all LVAD patients. Can occur due to improved preload on that right ventricle that isn't used to all that flow. So it can worsen ischemia and worsen remodeling over time. So this can be acute or it can be chronic, but these patients are their presentation is going to vary based on if it's acute versus chronic. If it's more of a chronic issue, they are going to present as heart failure. So maybe they would have signs of fluid overload. Maybe they'd have worsening fatigue, shortness of breath, and they may end up eventually in shock. Acute changes that can cause RV failure would be things like arrhythmia, pulmonary embolism, possibly fluid overload. So thus the patient would have signs and symptoms related to each one of these disease processes. We're going to see a low flow, low power, low pulsatility index. We can diagnose RV failure via echocardiogram, and then each of the individual acute etiologies are diagnosed differently. If it's strictly RV failure, these patients are treated with inotropic support and then possibly pulmonary vasodilators. So now that we've got a good differential diagnosis and then what we're looking for specifically to help make a diagnosis of each one of those conditions, let's talk about our patient. So on physical exam, they've got no JVD, they've got no crackles, they've got no edema. We look at the specific LVAD, we can see that there was a low flow alarm. The power is normal currently, but it's running a little bit slower than it should with a low flow state at 1.8 liters per minute. So, what does this new information do to our differential diagnosis? Well, hypovolemia is still on the list. Hemorrhage would still be on the list. Suction events, arrhythmia, possible outflow kink. And what were we able to rule out now by doing a pointed physical exam and then looking at the LVAD parameters? So, there's no high flow state, so aortic insufficiency and sepsis is ruled out. There's no increased power, so pump thrombosis and sepsis is also ruled out. And then we don't have a fluid overload state. So we're not suspecting RV failure. We're not suspecting things like tamponade. So what workup should we do for this patient, starting with the lab work? Well, we're going to do a complete blood count because we're going to look for signs of stress or infection. We're going to look at the patient's hemoglobin for signs of blood loss. We're going to look at the patient's platelets, which, if they were low, could indicate hemolysis. We're going to make sure to check coags because we assume our patient is on Coumadin, so we're going to need to check their INR. If they're therapeutic versus subtherapeutic, adds back in some things into our differential diagnosis. We're going to probably look at a lactate for perfusion purposes. We're going to want to do an LDH to look for signs of hemolysis or pump thrombosis. We're going to look at a patient's electrolytes. In this case, let's do a complete metabolic panel. So we would look at things like the patient's sodium. If it was low, that might indicate increased volume status. If their BUN to creatinine ratio is high or they've got an AKI, that might indicate poor perfusion to the kidneys, might indicate a hypovolemic state. We're going to want to look at the patient's bicarb. If their bicarb's low, that would indicate poor perfusion and organ dysfunction, acidosis. We'd also want to look at the patient's bilirubin to look for more signs of hemolysis. For imaging, we'd probably want to do a chest X-ray for this patient. We'd probably want to do things like an EKG. EKGs are unchanged because of the patient's LVAD. There's nothing special you have to know about reading them. A lot of times they'll have signs of cardiomyopathy. Maybe they'd have a pacemaker or ICD also present. So for lab work, let's look at our patient's CBC. Their white count's 9, hemoglobin's 12, platelets 179. So normal, no help there. INR is a little subtherapeutic at 1.8. Lactate's a touch high, but our LDH is not greater than 3 times the upper limit of normal, so we don't have to worry about hemolysis. Looking at the patient's complete metabolic panel, not much jumps out to me. Their bicarbs may be a touch on the low side. Their BUN to creatinine ratio is high. Without knowing what this patient's creatinine baseline is, we would probably just assume that that's an AKI. So hypovolemia is coming up on the differential. AST ALT is normal. Sometimes those will be elevated in just patients that have heart failure secondary to portal congestion. Bilirubin's normal, so hemolysis certainly less likely. So our imaging, we do a chest X-ray. We see that heartmate 3 present and the patient has an ICD. Bedside echocardiogram, we don't see any pericardial effusion. We see IVC collapse with respiratory variation, which can be a sign of hypovolemia. We see the LVAD in place with no free fluid in the abdomen, and we do an EKG that shows a left bundle branch block. So based on this new information, what differential diagnosis are we left with? Well, we're left with things like hypovolemia for whatever cause. LVAD inflow cannula obstruction. Well, we don't think it's going to be a thrombosis, but it could be something from malposition or possibly related to outflow graft obstruction or kinking. Arrhythmia is still on the list since those go hand in hand with hypovolemia and suction events, and then as well as pump malfunction. So some of this I can investigate. Otherwise, the person who put the LVAD in is going to need to investigate. So what do we do for our patient? So they came in, we correctly diagnosed the fact that their LVAD was working based on having a hum. We were able to obtain a blood pressure on them, which was low. We gave them a 500 cc fluid bolus, which improves their MAP. We didn't see any signs of fluid overload after we corrected this. We're probably going to place them on telemetry to monitor them for any arrhythmia. We did a bedside echocardiogram to rule out any kind of acute suction event, which also would have been treated with the IV fluid. So we should probably get them the heck out of your emergency room and get them to a place where their LVAD can better be assessed, since a lot of the other things that are in the differential diagnosis for this would be more mechanical in nature. You're always going to want to call the LVAD center pretty much as soon as this person hits the front door. Let's play devil's advocate, though, for a second. Let's say they get worse. So one of the other things we should be familiar about is when to start chest compressions on a patient with an LVAD. So this is by the American Heart Association from 2017 from their ACLS guidelines. Um, so the first thing we would want to do is there a hum when we're assessing a patient? So this is a patient that you're assessing when you're wondering, do I need to start CPR on them? So they're tunded, they're not breathing, they've got signs of poor cap refill, their mentations on where they're not conscious. So because you can't assess using a pulse, there's a couple of steps to do first when deciding if the patient needs CPR or not. The first thing would be to do is evaluate the LVAD. Is it working? So is there a hum? No. If that's not present, then you try to restart the LVAD, check the power supply, check the drive line connections. If it works, meaning that there's a hum, your patient's still in distress, to the point where you're contemplating CPR, then you're going to want to check a map on them. If it's less than 50, then they recommend starting CPR. The other gauge is having a post-end expiratory CO2 of less than 20 by capnography. This can also be used in patients that are on a ventilator. So a level of 20 corresponds with a cardiac output of about 1.5 liters per minute in animal models, and thus is another indication for beginning CPR. So let's do a quick practice case so we can see how all this stuff is applied. We have a 56-year-old male with history of ischemic cardiomyopathy, end-stage heart failure, managed with an LVAD. Presents to the emergency department with complaints of fatigue and dark-colored urine over the past 2 days. His spouse reports that the LVAD's been alarming for high power. He denies chest pain, shortness of breath, or bleeding. On examination, his mean arterial pressure is 65. His physical exam reveals a continuous hum over the precordium with no audible heart tones. Labs reveal hemoglobin of 12, lactate of 3.2, LDH of 1200, bilirubin of 2.1. The LVAD interrogation shows increased power consumption up to 10 watts, reduced flow, and normal RPN setting. So what do you think is the most likely cause of this patient's symptoms? A, hypovolemia, B, pump thrombosis, C, right ventricular failure, D, outflow graft obstruction, or E, sepsis? If you need to take a minute and pause the video, feel free, but give it a thought and come up with a conclusion. So let's pick out some highlights of this. The patient doesn't appear to be fluid overloaded. Their map is a little bit on the low side, but the dark urine is kind of a red flag. And then also this paradoxical flow to power consumption that's present. So all of these things scream B, pump thrombosis. We can see A is probably not right because they would not have there's been no history of volume loss, but also their hemoglobin's appropriate, so we don't have to worry about hemorrhage. But that low flow state should be accompanied by low power consumption if hypovolemia was the cause. Right ventricular failure typically causes low flow, but is not associated with hemolysis or high power. I would expect the patients to have more signs of fluid overload on exam. Outflow graft obstruction would also reduce flow, but usually does not cause significant hemolysis or have high power. Sepsis, again, would present with things like fever, leukocytosis, maybe worsening lactate due to the hypermetabolism, without any hemolysis, would also not have a low flow state.